I presume you guys can see my screen now. That was a great panel, and I must admit, having been at this for many years, it's nice to see the enthusiasm going forward. The the scars on my back from those that said robotics is never going to go anywhere are still pretty tender. So I'm glad to see that there's others picking up and looking at this and really taking the technology. But what I'd like to share with you is sort of another step in the evolution, going into the cervical spine with the robotics and navigation, where we are now and where we're going to go with this. Again, in the spirit of disclosures, I do have relationships with each of these entities. Many of them do have robotic platforms, as you know, and I'm a consultant to them as well. I showed this on my first one. It really does allow us to boldly go where we have not been able to go safely or efficiently before. And using this technology, we have marched all the way up the spine and we've marched all the way down the spine now. So we can cover the full gamut of pathology that we are faced with. Now, cervical pedicle screws are not mainstream. We haven't taken advantage of this. Years ago, we figured out that cervical pedicle screws versus lateral mass screws are biomechanically much better. But anatomically, they're difficult screws. It's tiger country up there. You look at some of the papers that were out there. This was a paper from John Heller a number of years ago. The pull-out strength was higher for pedicle screws and lateral mass screws. And the uniplanar fatigue analysis was also much better for pedicle screws and lateral mass screws. Now, it doesn't take much more than a little bit of orthopedic intuition to figure out that, yeah, that's the case. You've got a longer screw, you've got a tighter canal with it. And then here's another paper that came out of Japan looking again at the limitations of the lateral mass screws compared to cervical pedicle fixation. And you can just see the 2- and 3-fold increase in pullout strength. So I'm faced with a lot of revision surgeries, unfortunately. I do a lot of revision cervical as well. And they've already had lateral mass screws. They've had full laminectomies, so you can't wire them. You can't put anything else in the lateral mass. Somehow you have to try to get fixation, to get the head back up where it belongs. And this is where we've taken the technology we have today, knowing the biomechanics and knowing the anatomy, and been able to harness that to the benefit of our patient. So cervical pedicle screws are not the standard of care right now. They do provide more rigid fixation. They can help save the number of levels that you need to fuse, particularly in those revision situations or osteoporotic, poor bone, rheumatoid type situations. But it is a jungle. You do have a lot of nerves in the area. You do have the vertebral artery in the area. Now, there's this sentiment that the spinal cord is at risk. And if you look at the pictures on the far right, look at the CT scan, look at that C5 one's the best one. And if you look at where the starting point of your cervical pedicle screw is compared to the equator of the spinal cord, you're well below it. So it's unlikely that you are going to injure the spinal cord. And that's been the sentiment that everyone's been worried about. But that's not the big risk. The big risk are the nerves and the vertebral artery. And why are they risk? Well, obviously the cervical pedicles are much smaller. They do have a much higher medial convergence angle. The foramen itself is much smaller. If you trace out the anatomy of the cervical nerve roots, they lie lower in the foramen than what we're used to in the thoracic or lumbar spine. So that means that the superior breach is going to be far more susceptible to injuring the nerves. And the nerve root angle that it exits at changes as you go from C2 all the way down. So if you look at C3, it's about 90 degrees, but as you go down the spine, you see it's changing with each level as we're going down the spine. So there's a lot of anatomical variation here. And to tie in with my previous talk, the importance of pre-op planning, getting those screws exactly where they want to be. Now, looking at CT scans, we know that the cervical pedicles can accommodate almost always, 98% of the time, a 3.5 millimeter screws. And the width of the pedicle is very, very, very rarely less than 4 millimeters. You've also got to look at the shape of it. And the cervical pedicle screws are elliptical to triangular in cross section. Sorry, the cervical pedicles are elliptical to triangular in cross section. And the medial wall is thicker than the lateral wall. So if your drilling is off, if the screw is off, it's going to bounce off the medial wall typically towards the foramen transversarium as opposed to into the epidural space. So that's why lateral breach and vertebral artery injury is much more common. Now, the way we typically did this is by doing a small foraminotomy, getting a nerve hook or a ball tip probe, feeling where that pedicle is, and then a combination of manually and visually aligning the screw, and then either drilling or probing or whatever your technique of choice would be to get that fixation that you needed. So this is where we started doing the robotic placement and navigated placement of cervical pedicle screws, because we know they're advantageous, but we also know that the anatomy is complex and there are substantial risks. So a number of years ago, we set out to look at our experience with the robotic guided cervical pedicle screw placement. This was a retrospective review. We looked at our consecutive patients who underwent cervical pedicle screw placement. We looked at their post-operative CT scans, and all of these were my patients. I was the only surgeon in this one. We fused the pre-op CT to the post-op CT and then compared the planned versus the actual screw placement at the midpoint of the pedicle with a resolution of 0.1 millimeters. And then we did the requisite looking at the charts for the technical issues and the intraoperative complications. So here's one of the examples of the fusion where we've got the pre-op CT, the post-op CT fused together. You can see clearly where the screws are, and you can see the yellow and blue lines are my preoperative plans. So you can see in these screws, I was able to get the plan pretty close. The one, the top left that you can see, the blue line, were a little more lateral in terms of it, but the trajectory is pretty close on. So this is the way we analyze these cases. And in this first group, we had the first 10 patients that we looked at. Typical group, 64 years of age, cervical spondylosis, post-laminectomies, fractures, metastatic tumor group there. We had no intraoperative complications related to the placement of the pedicle screws. We were able to place all 78 screws robotically. Postoperatively, we did note 10 pedicle screw breaches. Interestingly, all the breaches were medial and less than 1 millimeter. So despite what I said about the medial wall being thicker, we were medial with it. And I suspect that this is because with the pre-drilling, I was pre-drilling that medial wall and making that the more vulnerable way to go for the screws. So here's the breaches. We had the breaches you can see on the right side, the left side. There were 5 on each, 2 at C2 on the right, 3 at C4 on the right, and then 1 and 1 on the left for those breaches. But none of the breaches had any clinical significance. And then this was the analysis of the angle in the axial and sagittal plane when we looked at the left screws and the right screws. And on average, the deviations were about 1 millimeter at each one of those spots. So here's a typical case. This was a 51-year young female with a severe cervical myelopathy and essentially a drop head syndrome. You can see she has no paraspinal muscles holding her up. You can see the extent of the cervical compression from her degenerative changes there. She was pretty frail, and there was a lot of debate. Should I go in front, from behind? Do I have to combine? What I wanted to do was realign her, get her able to hold her head up and decompress her, and then decide, do I need to go back in front at a later date? So here's my preoperative plan. And again, planning above and below, planning always more than what I think I may need in the operating room, which, to add to the panel, that's what I would suggest to those of you that are doing preoperative planning. Over plan more than what you need so that you're able to call the audible in the OR if you have to. And then here you can see the plan, and here's the execution at multiple levels going down. You can see it's very tight territory, but here's the intraoperative view with all the screws placed, all placed very accurately. And then here's her post-op films where I was able to get her lined up, get her head up. And here's her MR scan showing the decompression. And then we've got really good fixation with her CT scan. And she's gone on to ultimately do much, much better than I thought. She's become sort of one of my star patients right now. Her myelopathy resolved. She's turned her life around. So I was really pretty pleased with it. And here are her VAS and NDI scores. And you can see at 9 months, she's substantially improved in her function and her pain. So the study that we did starting out with this showed that placement is feasible. It is good to fixation, and we got clinically acceptable results, and the medial breaches really did not result in any clinical consequences. And for years, we were putting hooks and wires into the cervical epidural space without even thinking about it. So the medial breach, I just don't worry about that anymore. And especially if you remember how I pointed out that the equator of the epidural space, you're below that with your starting point of these screws. So the issue is really protecting the nerve roots and the vertebral artery. And we've subsequently published our longer-term results of the cervical pedicle screws. Again, very similar in terms of the breach rate, but the clinical outcome and the fixation was very, very good. Now, this is another case, and this is taking it up even one more level. So this is a 58-year young female with tremendous neck pain, back pain, difficulty walking due to her posture, complicated past surgical history. And you can see here, from 2009 on, she had multiple surgeries. It started with an L4 to S1 fusion, then cervical spine, then T2 to the pelvis, then extension from C4 due to PJK, then screws pulled out, then wound dehiscence, then multiple INDs, then halo, then VAC, and then she comes to see me in the clinic. So here she is. This is how this lady was wheeled in because she really couldn't get up and walk. Chin on chest, cachectic really because she couldn't barely eat. She couldn't open her jaw enough to get food into her. Here is her CT scan, and you can see that the spine just buckled forward on her. And this becomes a very complex situation in someone who's physiologically compromised. So my plan for her was multiple stage procedures. The first stage was to go posteriorly, do multiple level releases, Smith-Peterson osteotomies, and put her in halo traction and see what I can get. And then the second stage, C5 down to her existing hardware, maybe a pedicle subtraction osteotomy, and she may even need a third stage, something anteriorly. But I like to take these in little steps forward, moving ahead one step, never going farther ahead than what you can retreat from, so that you do everything you need to do, but not anything more than you have to do. So here was the first step, exposing strategically. You can see the existing hardware she had in. and doing the multi-level osteotomies, putting her in traction, and she released really, really well and started to move very nicely. So she was in traction about 10 days, got her back to the operating room, and then realigned her, as you can see here, got her back, linked her to her previous hardware, and this is what she was doing after all that. So again, using the cervical pedicle screws, getting her aligned, doing the pre-op planning, and working at this in stages to go from what you see on the left to what you see on the right. So if you look through the literature, there's really only one paper that I could find. I'd welcome if anyone knows of other papers, but looking at the accuracy of direct visualization versus the computer navigated or robotic placement of pedicle screws that's out there. But they looked at direct visualization and navigation. They had 3 breaches in the direct visualization, 9 breaches in the navigation group, which statistically didn't show much of a difference. They had 1 high-grade breach in the navigation group, but again, it really was not a clinically significant issue as you read through that. So that's where we are with cervical pedicle screws. I know we're going to get a lot better with it. Martin had mentioned this earlier that the med device manufacturers really have not embraced this area yet. The kit that I'm using is a makeshift kit that I put together with an old pelvic trauma set that has longer drill bits so that I could anchor to the neck and get those trajectories drilled that I need to drill. So this is something that's coming. I'm sure they're going to start working on it because we're seeing a lot more revisions at the cervical thoracic junction and a lot more primary biomechanical issues in the cervical spine where pedicle screw fixation is really going to help us. So with that, thank you very much, and I'm happy to entertain any questions.
Izzy, it's Martin Pham. Great talk as always, and I think we share a kindred spirit in an exploration into the cervical spine. At UCSD, we've also fashioned together a makeshift sleeve to fit a lot of the instruments as well that we're starting to trial out soon. But a question: how do you fixate the head? What's your preference? Is it a Mayfield? Is it tape? Do you, latch on with a spinous process pin? Do you, hook the robot up to the Mayfield? What's been your investigative results so far?
So as with everything, it's an evolution. It's trial and error. I started with the Mayfields. I'm still using the Isador robot, so it's still anchored to the OR table, not to the patient in any way. What I have evolved to, and I'm very confident in right now, is the pneumatic headrest that Mizuho sells for the Jackson table. You've got the bull horns on it, you've got the Mayfield clamps, and in a sterile fashion, you can manipulate the neck as you need to. So the workflow now for my revision cervicals is prone position with the Mayfield clamp in the Mizuho pneumatic headrest. I then flex the neck as much as possible, considering the safety of the cord and what pathology you're dealing with, because that facilitates the registration and the placement of the screws. So you've got to flex them right down. It opens everything up and makes the exposure that much easier. But clearly you don't want them flexed after. So once I've got the registration done and the screws in place with the Mizuho pneumatic, I then just release the flexion, put them in extension, move them to where I want them in 3-dimensional space, and put my rod in. And it just becomes so much smoother than the old headrest on the Jackson table where you had all the clamps and all of those knobs that you had to release and you'd have to scrub out. It just made it very difficult. Now, fixating the cervical spine is the next big issue. And for those that, I don't know if anyone in the room used the Spine Assist system or the Renaissance system. Those were the two original robots that predated the Mazor X when Mazor, prior to Mazor being acquired by Medtronic. We had a series of different clamps. There were small clamps that you can actually put on the neck, and I have a couple of those clamps left over. So that's what I still use because they're small, they're not obstructive. Now you can use the MIS clamps in the current Mazor X set. And what I have also done is taken K-wires and placed K-wires into a spinous process or a lateral mass and attached it to the MIS clamp so that the cervical spine doesn't snake underneath you when you're drilling or applying pressure. So it gives you that fixation while you're doing that. So those are the things that I've picked up over time. They get the screws in accurately and still achieve the correction that you need.
Those are great tips. One other question, do you use scan implant or a CT to fluoro with the Mazor system? Because we tried it once with the CT to fluoro and the system, I mean, it registered, but each time there was a shift. And I think it was just getting, I mean, the teeth were in the way and the bodies were so small that I think the next time will likely be scan implant. But what's been your experience on it?
So I've used scan implant twice in the cervical spine. Both were lower down in very obese osteoporotic patients that I knew we were going to have difficulty registering the cervical-thoracic junction. So that's where I'll use the scan implant, where the shoulders are in the way, they're obese, and they're osteoporotic. All the other times, it's a CT to fluoro, and again, positioning the head appropriately with the pneumatic headrest to get your registration really helps. So for C4 down to T2, you really don't have to do much in terms of the positioning to get it. But when you're doing the occiput C1, C2, C3, you really want to get the jaw out of the way as much as possible. So you can use the Mizuho to adjust the head and neck to get the jaw out of the way for your fluoroscopic images to make it easier to register.
That's great. Thanks for your insights.
Izzy, it's Pat Johnson. That was an inspiring lecture from my perspective because I do a lot of cervical deformity work, and I think you've changed some of my perspectives about how to do some of these things with pedicle screws now, because I've always been a little more on the traditional side, go up to C2, that's the workhorse of the cervical spine, and just the one case that you presented, stopping somewhere in the upper cervical but short of C2. I think that it's going to push that forward, because I think there are some people you can do fewer segments. That's really what it's all about. And thank you for such a great presentation. That was great. You've inspired me.
Thanks for the kind words, Pat. You and I are the same vintage, and we're inspiring each other. I just wish I could ride a horse and look good in a cowboy hat.
I'm just looking good these days is all I'm working on. So.